Up next, Deepak Bhatt is joined by Dr. Arshad Quyyumi, Professor of Medicine and Director of Cardiovascular Research at the McMurray Medical School in Atlanta, Georgia. They discuss PRESERVE AMI, intracoronary infusion of autologous CD34 cells in patients with left ventricular dysfunction after STEMI.
Welcome.
Thank you.
It's really great to have you here, and in particular to talk about stem cell trials. There have been a lot of different trials that have been done in terms of infusions in the coronary world, in the heart failure world, and most of these studies haven't been really rigorous, but you've conducted a very rigorous study. Could you tell us a bit about it?
Yes, this was a phase 2 trial involving 160 patients who had recent ST segment elevation myocardial infarction and underwent administration of either autologous bone marrow-derived CD34 cells or placebo, and were followed over a period of 6 months for functional endpoints and will be followed up for up to 3 years for serious adverse events and major adverse events.
Well, that's great. 160 STEMI patients with randomization to placebo or the intracoronary infusion of the autologous CD34 positive cells, 6-month functional outcomes, and then 3-year clinical outcomes ultimately. So great, you've got it all interwoven into the trial design. Could you say a little bit about what type of cells these are, these CD34 positive cells, where they're from and where they're going?
These are bone marrow derived. These are a small percentage of mononuclear cells that are present in the bone marrow. As you know, there have been a number of studies conducted with bone marrow mononuclear cells, not differentiated in any way in the past in this particular condition. And the results have been mixed, as you said, with meta-analyses showing that in more than 2,000 patients that have been randomized to various studies, that the ejection fraction change has been in the order of about 3% or so over time. Now, if you look at which cell types within the mononuclear cell population appear to be most angiogenic and most able to repair and regenerate, then it appears that the CD34 positive subpopulation is likely to be contributing greatly to this. So this product was really developed in order to concentrate the CD34 cells from within the bone marrow by selection, and then to administer them at a fairly high dose, much higher dose than has ever been given before in this condition in people with ST elevation myocardial infarction.
So these are the patient's own bone marrow cells harvested from the patient, then purified essentially and enriched, and then infused via an intracoronary catheter.
Yes, with the balloon occluded several times.
And from a technical procedure, does it add any meaningful time or complexity to the procedure? Is this something that could be easily done?
So the way the protocol works is that the individuals had bone marrow harvest within 10 days of having had myocardial infarction, and subjects were selected based on the fact that they had LV dysfunction more than 4 days afterwards. So they had to have an MRI-EF of less than 48% to be entered into the study. So we selected individuals with reasonably large MI. These cells were then harvested with a mini bone marrow harvest under conscious sedation. Up to 300 mLs of bone marrow product was removed, shipped over, and the CD34 cells were then selected, concentrated, and sent back. And then the subjects were taken back to the cath lab and had the infusion made down the infarct-related artery with the balloon inflated within the stent that had been placed about 10, 11 days beforehand.
Very interesting science, extremely rigorous trial design. What were the results?
So we have 6 months results for functional endpoints, which primarily was perfusion defect measurement using SPECT, MPI, measurement of RTSS, severity score, and secondary endpoint was change in ejection fraction over the 6-month period that was measured by MRI in as many people as we could measure it. Then the other primary endpoints were occurrence of adverse events, serious adverse events between the treated and control group, and MACE events, which included deaths, MIs, and heart failure admissions and revascularization. And that follow-up so far has reached a mean of about 12 months for the group. What we've found so far is over this 12-month follow-up, the mortality is significantly lower in the treated group compared to the placebo group. When we examined all of the major adverse cardiac events, there wasn't a significant difference between the groups. But when analyzed by the dose of cells received, there appears to be a dose response in terms of reduction in MACE events or trend toward reduction in MACE events with increasing cell dosage. Similarly, when we examined the SAEs, there wasn't a significant difference when compared between the placebo and the control group. However, once again, if there was a dose-response relationship such that at higher doses of 14 million and above, CD34 cells administered led to a significant reduction in events. The SPECT perfusion defect size was not different between the treated and placebo group, and the ejection fraction change was also not different between the treated and placebo group, except once again that there was a significant dose-response relationship so that individuals who received a higher dose of cells had a greater increase in ejection fraction.
So with the higher doses, a greater increase in ejection fraction and a lower MACE, did the trend towards greater doses producing greater effect also extend to mortality? I know you said in the overall study mortality was lower in the treated arm. Was there also a dose-response relationship for that?
There were 3 deaths, which were all in the placebo group, and the treated group had none. So it's hard to examine that, I think, so far, because we have a very short follow-up in terms of deaths. It's a mean of 1 year.
Right. But in any case, some really interesting signals that the higher dosing strategy might both improve LV function and thereby presumably reduce major adverse cardiovascular events?
Yes. We had conducted a previous phase 1 study on the basis of which this larger phase 2 study was performed, and that also tried to examine a dose-response relationship between the cells, and we did find one and settled on the fact that greater than 10 million cells should be given, which is how this trial was designed. But we find that actually it's probably the greater than 14 million that appears to have the real benefit.
So more is better in terms of number of cells. And in terms of things like arrhythmia, any concerns in any of the dosing arms?
There were really no difference between these other events between the 2 categories.
And allergic reactions? Any
None.
concern?
These were autologous cell products, so we were not expecting any, and there weren't any.
Sure, good point. Any concerns? I realize that you might not see it in the sample size or with this duration of follow-up of any off-target effects?
So far, we have not seen anything. And again, in these other studies that have used autologous bone marrow products, there hasn't really been any off-target signs of any abnormal side effects.
Yeah, no, that's at least theoretically, it seems a large advantage of the autologous approach. Great. Well, in the few seconds we've got left, any closing remarks or points you want to make to our audience about this very interesting study?
Well, I think these results are really exciting in the sense that we are beginning to see a dose-response relationship between the administered cells, which are clearly enriched for a progenitor pool from the bone marrow. And really, it will require a much larger endpoint study to confirm these findings, as well as a longer follow-up of this current cohort, which we aim to do for up to 3 years.
Well, it's certainly an exciting initial step in regenerative medicine for patients who've had large STEMIs where they're left with left ventricular dysfunction. Thank you very much, and congratulations on a provocative and interesting and important study.
Thank you very much.